My name is Mary Limbe. I'm the coordinator of this evening's program, and we are pleased to have the pleasure of Phoebe Wamalwa presenting to us. She's from the University of Nairobi, but now is a pediatric endocrinologist at sorry, Phoebe, where are you based? Sorry,
Kajiado County Referral Hospital.
I'm so sorry. It's just decided to listen. Yeah. So we're really pleased to have you share with us the knowledge here. And guys, you're invited to put your questions in the question and answer chat, and then they'll be addressed at the end of the talk. So over to you, Phoebe, please.
Okay, thank you so much, Dr. Limbe. So welcome, guys, to this very last session that we are having of our diabetes series. So today we are going to talk about intensification of insulin therapy with a main focus on our type 1 diabetes children and adolescents. These are my objectives. At the end of this presentation, we will have answered these questions. Number one is, how is insulin secreted and regulated? What are the types of insulin? Which regimens of insulin administration do we know? What is insulin intensification? Why in insulin intensification, why is it important? And then we shall look at briefly on some landmark studies. And then how do we switch to basal bolus? This is a big question to a number of our clinical colleagues. And then after that, we shall finish with how do we adjust insulin doses. And these last two subtopics will be laced with a number of case scenarios that we shall discuss. And then I'll expect that we get active and just type into the question and answer chat box for us to move on quickly. So as a way of introduction, we know that type 1 diabetes occurs because of destruction of pancreatic beta cell, leading to either absolute or partial insulin deficiency. And by the time the child or an adolescent is getting symptomatic, then it means around 80 to 90% of the pancreatic beta cells have been destroyed. And so this is basically where our pancreas is. And this is the destroyed pancreatic islet cells leading to type 1 diabetes. So quickly on how insulin is secreted. I'm talking about this because I assume that we know what insulin is as a peptide hormone. So this is our, let me just get the pointer. So what you can see here is our islet cell. This blue one is the cell membrane, and it has a number of channels. You have a channel that allows glucose entry into the cell. You have a channel that allows insulin to get released from the cell, and then you have the calcium channel and also the potassium channel. So what happens is whenever we have glucose that is circulating in the bloodstream, it gains entry into the islet in the beta cell via the glucose transporter 2. It undergoes metabolic reactions right into the mitochondria where glycolytic processes take place with subsequent release of energy in form of ATP. When this ATP rises in the cell, it causes the closure of the potassium channel, and the closure of this potassium channel causes depolarization of the cell membrane, with an end result of opening up the calcium channel with calcium entry into the cell. And as the calcium enters into the cell, the insulin is now released from the insulin-containing granules into the bloodstream. So basically, that is how it works. So what we are seeing here is insulin release is dependent on glucose entry into the beta cell. So the next question is, how is this insulin secretion regulated? The release of insulin from the beta cells is usually in a pulsatile fashion. So what you see here is after every 4 to 15 minutes, this release of insulin. But then what is clear here is there is the basal form of insulin that you can see here where my laser pointer is. That is the basal form of insulin that is always available, released into the body, whether the person is fasting, the person is sleeping at night, the person has eaten, we always have this basal insulin. And it's very important in growth and development and normal functioning of the cells. However, when you ingest any starch or glucose, what you find here is the glucose levels in the bloodstream rises. And as a result of that, there is activation of release of a bolus of insulin to bring down the excess glucose to the basal level. So for instance, if in the morning you've taken your breakfast, your tea and bread, the glucose will rise, and subsequently the insulin level will also rise to bring it to the basal level. Same at lunchtime, you take your ugali and beans, or ugali and beef, the glucose levels rise, and it's followed by an increase in the bolus, release of insulin to bring the glucose to the basal level, and same to dinner. So at the end of the day, you're having what we call the physiological pattern of the basal insulin and the bolus insulin in the body. And this is how a normal body functions. Basal, bolus, and we're going to talk so much about this in the subsequent slides. So what are the available types of insulin that we know? We know that we have the rapid-acting insulin, and the rapid-acting insulin are the likes of aspart, glulisin, and lispro. And what is a characteristic feature of this is they have a rapid onset of action. Just around 15 minutes, they have started acting, and they take around half an hour to 1.5 hours to peak, and then an average of 5 hours duration in the bloodstream. And an example of aspart that we have is Novorapid, Lispro is Humalog, glulisin is Apidra. And then the other form of insulin is short-acting insulin. It's called short-acting because it takes roughly around half an hour to 1 hour to start acting, and then it peaks at 2 to 3 hours, and then the duration is approximately 8 hours in the bloodstream. So example of short-acting is what we largely know as regular insulin or soluble insulin, easily available in our hospitals, or even a brand name of Actrapid that right now we are using in our CDC centers. Then we have intermediate acting insulin, and largely this one starts acting within 2 to 4 hours of injection, takes 4 to 10 hours to peak, and then it lasts up to 18 hours. It does not last for 24 hours. And that's why for patients who are on NPH, which is an intermediate active insulin, you need to give as a BD dose. So examples of NPH are the likes of Insulatard, the likes of Humulin N. And then we have long-acting insulin. And these are called long-acting because they almost, like glargine, which is Lantus, will take around basically 24 hours. It covers 24-hour clock in the body. And so what happens here is the onset is around 2 to 4 hours. It has almost a negligible peak. And then, as we say, the duration is 24 hours. Another long-acting insulin that we have is Detimia. But it's important to know that in as much as, some studies have shown it may last almost 24 hours, a number have actually shown that it just lasts around 18 to 20 hours. So in some cases, the patient will require BD dosing. Then we have newer acting insulins, like ultra-fast acting insulin that just takes 5 minutes to start acting, and then 30 minutes to peak. Then we have the ultra-long acting, Degludec, that works for more than 24 hours. So this is basically what we have talked about. When you look at this chart, the rapid acting insulin will basically have an onset of action of around 15 minutes. And by the time we are coming to 5 hours, they are no longer acting in the body. When you have regular insulin that now lasts up to 8 hours. And then we have NPH here that lasts up to around 18 hours, 16 to 18 hours. And then we have insulin glargine or Lantus that lasts for 24 hours. And then Detimia here in purple that almost covers 24 hours, but not absolutely up to 24 hours. So having said that, what regimens of insulin administration do we know? It's important to mention even the outdated regimens and the ones that are not recommended, for us to know the reason as to why they're not recommended. And so we have the sliding scale, outdated, fixed combination insulin regimen, not recommended. And then now we have the recommended intensive insulin therapy. So starting with sliding scale, what you can see here is it basically works on a reactive approach where smaller doses of insulin are given when the blood sugar is lower, like you can see, and larger doses of insulin are given when the blood sugars go higher. And up to a certain amount of sugars in the body, if for instance less than 8 millimoles, you'll find that no insulin is recommended. However, the American Diabetes Association advises against using the sliding scale. Why? Because it does not mimic the body's natural insulin response, as we saw earlier, so leading to fluctuations in glucose levels. It's a reactive approach. It delays insulin until hyperglycemia appears, and it does not meet basal insulin requirements, as you can see here. And it promotes, as a result, large swings in glucose control. Then we have fixed or premixed insulin, and it's not recommended after 13 grade. And this is where a patient is given 2 to 3 injections daily, where a patient gets breakfast injection. Like for Mixtard that has been in the market, you'll find it's a combination of rapid acting insulin and intermediate insulin fixed together. So in the morning, they'll be given an injection and then another injection in the evening. And then at lunchtime, you'll find that there's some rapid acting or intermediate, some rapid acting insulin usually, where you can give a regular acting insulin or perhaps aspart or glulisin. So this is basically how the graph looks like. So you have already pre-mixed your rapid acting insulin and NPH. So you give your breakfast, you're not able to adjust the amount of insulin that you will give in terms of rapid acting to the breakfast you're giving because it's already fixed with the NPH. And then at lunchtime, there's no coverage with a pre-meal bolus. And then dinner, again, we have already a pre-mixed combination. So it becomes really difficult to adjust this with the amount of meals that the child requires. And so it's not recommended because it does not mimic the normal physiological insulin glucose interplay. So it will be riddled with high and low blood glucose level. And it does not enable appropriate individualized insulin dose adjustments with food, illness, and exercise. And this is very important in children and adolescents because they are growing. And so growth interference happens a lot in this regimen. So this strategy was therefore challenged by the DCCT study that we're going to discuss shortly that demonstrated that intensive therapy was superior. And therefore, it's not recommended in children and adolescents. The next discussion is what is insulin intensification? So insulin intensification is defined as the use of multiple doses of insulin or continuous subcutaneous insulin infusion, that is using a pump. But this is not just it. It has to be accompanied with more frequent blood glucose monitoring and timely adjustment of insulin doses according to the blood glucose levels, the diet that the patient is taking, and the anticipated exercise. And there should be more frequent visits to the therapeutic team. This comprises of basal bolus, where you use multiple dose injections, and insulin pump or continuous subcutaneous insulin infusion. So when you're looking at the basal bolus regimen, we are saying that this is the recommended insulin regimen for type 1 diabetes because it's closer to the physiological norm. This is the slide that we started with. So it's a combination of a long or intermediate acting insulin. If you're using a long acting insulin, you'll give it once. If it's intermediate, you'll give it twice to cover the basal needs. And then it will be combined with boluses of either a rapid acting insulin or a short acting insulin that is given before meals. And the long or intermediate acting insulin constitutes usually 40 to 50% of the total daily insulin dose, while the balance of 50 to 60% is now divided into 3 as either a rapid or short-acting insulin that is given before the meals, but it's however adjusted with the carbohydrates that the patient is taking. So these are basically just examples of the long-acting insulin that we have. I believe we have come across the insulin glargine, or well known as Lantus, the brand. We also have Levemir, that is detemir injection. So usually 40 to 50% of this will be basal insulin, and then you will combine it with either rapid or short-acting insulin. Then we have the intermediate regimen, where you do not have a long-acting insulin, then you are allowed to use intermediate acting insulin. And what do we have is NPH. So NPH provides a basal insulin cover as an onset of action of 2 to 4 hours, as we saw earlier. It peaks at 4 to 10 hours, and it has a duration of around 12 to 18 hours. So it needs to be given twice. And then, of course, as you're giving twice 2 injections of intermediate action, remember you also have to cover the pre-meal boluses of pre-breakfast, pre-lunch, and pre-supper. So the patient will basically have 5 injections in a day. And just like the long-acting insulin, the total daily NPH dose should be 40 to 50% of the total insulin dose. And it's given twice daily, with 2/3 given in the morning and 1/3 in the evening. So examples are Humulin N and Insulatard that I know most of us know. These are just examples of the short-acting and rapid-acting insulin. So rapid-acting is like insulin Lispro, which is Humalog, or Aspart, which is Novorapid. Then the short-acting insulin is like Humulin R or Actrapid. Then the other intensive insulin therapy that we can use is continuous subcutaneous insulin infusion or an insulin pump. And we know that an insulin pump is a convenient way of administering insulin involving continuous subcutaneous infusion of rapid-acting insulin with boluses of the same insulin with meals. So we have the conventional pump and the closed loop. So in the conventional pump, what happens is the settings are pre-programmed into the pump with different basal rates set for different segments of a 24-hour period. And this is tailored to our patient's individual requirements. So this is the pump. So we have the operation buttons here for the setting. We have the, of course, the display and the insulin reservoir here, place for the battery. Then we have the cannula that, of course, will go into the subcutaneous tissue infusion set, the tubing that connects to the insulin reservoir. And then we have a closed loop system or an artificial pancreas, and this basically relies on glucose measurements via the continuous glucose monitoring that is transmitted to a delivery system or a pump that uses an algorithm that is computerized that now helps to adjust the insulin infusion that is based on the readings. So what happens here is there is continuous glucose monitoring that measures the glucose at all the times. And then the censored glucose is sent to the computerized algorithm that automatically determines the insulin dose, sends instructions to the insulin pump, and then the insulin pump delivers insulin to the patient. So it's basically closed loop because you can sense the glucose and calculate the amount of insulin to give, and you give the insulin. Then we have closely related to that is bihormonal systems. And this is a closed system that incorporates a dual chamber pump containing 2 hormones. That's the insulin in one chamber and glucagon in the other. So whenever the glucose levels go high, insulin release is increased. And when the glucose go low, you find that glucagon gets released. So this can actually be used with safety during normal activity and exercise. So the insulin pumps, we use usually rapid-acting insulin taken as a continuous basal infusion together with multiple boluses of the same insulin. And it automatically calculates the meal and all correction boluses. the infusion site needs to be changed every 2 days to avoid skin infections. What are the advantages of the insulin pump? Insulin is delivered only as needed, and hence nutritional intake may be liberal. The glycemic excursions, both as hyperglycemic and hypoglycemic episodes, can be reduced, and the system is convenient and portable. So it kind of gives parents and the caregivers peace of mind. So this is basically a summary of what we have been looking at. When you're talking about the basal bolus insulin regimen, you have 3 options. You can use your intermediate acting insulin, like NPH, together with short or rapid acting insulin. So if you're using NPH, 40 to 50% comes normally you use 40 to 50% of the total daily dose of insulin, and out of this you divide in that 2/3 is given in the morning and 1/3 in the evening, and then the remaining 50 to 60% you use it as either short or rapid acting insulin that is delivered before meals. Then we have the long acting insulin, like glargine and detinam or degludec. And again, 40 to 50% of the total daily dose given once a day at the same time. But remember, if you're using detinam, you will need to most likely use twice a day. And then you incorporate your short or rapid acting insulin at 50 to 60% of the balance of the total daily dose of insulin divided in 3 equal doses as premiums. Then if you are in a well-resourced center, you can put your patient on an insulin pump with training and various settings. So having talked about that briefly, then we ask ourselves, why insulin intensification? And I would want to take us through some 2 critical studies that have been done several years back that informed the need for insulin intensification. And these are, number 1 is the Diabetes Control and Complications Trial, famously known as DCCT study. And this was done from 1982 to 1993, 10 years as a controlled clinical trial. And the main aim was, besides testing the glucose hypothesis, it was basically to determine whether the complications of type 1 diabetes could be prevented or delayed. And then after that, after the 10 years, we had a follow-up study called Epidemiology of Diabetes Interventions and Complications. We shall call it EDIC. And this was done from 1994. It has been running even up to 2021 and still running. And it's an observational follow-up study. And the main aim was to determine the durability of the DCCT effects on the more advanced stages of diabetes complications. So whatever DCCT found, this study aimed to look at the durability of the effects of those complications in the past. So this is basically what we are talking about. Right from 1982, DCCT is initiated. 10 years later, in 1993, it's brought to a stop. And then Epidemiology of Diabetes Interventions Complication Study kicks off up to where we are. It's been running for over 27 years. So how was DCCT controlled trial designed? So it had 2 main groups. One group was given intensive therapy, and another group conventional therapy. And in the intensive therapy, what happened was they used at least 3 insulin injections a day using multiple dose injectables or an insulin pump, and it was guided by self-monitored glucose. They ensured that these participants have 4 or more self-monitoring blood glucose tests with a glucose target range of 3.9 to 6.7 as per. And a 2-hour post-meal target was less than 10 millimoles. On the other hand, the conventional therapy group was designed to have just 1 or 2 daily injections of insulin, and they could measure glucose either in urine or using the blood glucose. The glycemic target was not that strict. It was anything up to 13.5%. However, whenever they found a patient getting HbA1c of more than 13.5%, they could actually stop the conventional therapy and put the patient on intensive therapy out of ethical values. So this is basically a summary of what we are talking about. 2 main groups different arms in the intensive treatment. They randomized patients who had just had diabetes for 1 to 5 years. They didn't have any retinopathy. They didn't have nephropathy. They also had another arm that had patients who had stayed for 1 to 15 years with diabetes, and they had developed some early symptoms of nephropathy and retinopathy, and same to the conventional treatment. So as they were followed up, what they found was that intensive therapy reduced early stage microvascular complications by a whopping 34 to 76%. Now that is huge. And the intensive therapy cohort had a median HbA1c of 7%, while for the patients who were on conventional therapy, the median HbA1c was 9%. In the intensive therapy, it was largely safe, except for an observed increased risk of hypoglycemia, but this was not associated with a decline in cognitive function or quality of life. Then after the 10 years of DCCT, then a DIC study now, a follow-up study, kicked off, and it has been ongoing to look at the effects of the DCCT. So we now look to, we move to this follow-up study that that was carried out after DCCT. So this is what we are saying. During DCCT controlled trial, the patients who are on conventional therapy had a higher HbA1c of around 9%. And they were more likely, they had actually an increased risk of microvascular complications. The ones who were on intensive therapy, they had a HbA1c of around 7%, and the microvascular complications were very reduced, 34 to 76%. So after the DCCT study, what happened is they sent these patients to their original healthcare providers after they have taught them the intensive therapy. So all the patients, both conventional and intensive, were taken back to their home, and they were taught how to use the intensive therapy. So as they continued using the intensive therapy, 4 years later, what was noted in the EDIC study was the HbA1c kind of converged, in that the conventional therapy participants now started having lower HbA1c that was converging with the intensive therapy, which was good, basically confirming that intensive therapy is very good at lowering the HbA1c. But then this study also looked at the progression of the microvascular complications, because they imagine since the HbA1c in the conventional group has come down, then it follows without any doubt that the microvascular complications will also come down. But let's look at what happened. That's not exactly what happened. What they observed was in the conventional group, even after taking them to the intensive therapy and having the HbA1c come down to 8%, they continued having progression in retinopathy and progression in nephropathy. While the ones who had been initially on intensive therapy, the complications continued reducing just the way it was in DCCT study. So the question was, why was this happening? Because with the converging of HbA1c, the complications should also have converged, but they didn't converge, they continued diverging. So they actually named this phenomenon as metabolic memory, where the durable effect of complications of prior control continue getting manifested even after you have transitioned the patient to the intensive therapy. And this is very important to us, because then it tells us we need to start intensive therapy on our children as early as possible. Why metabolic memory? There are a number of postulations that have come up is because of the formation of advanced glycation end products. Because if you have persistent hyperglycemic environment in the body, what happens is we have accumulation or formation of these advanced glycation end products that now form on the various cell membranes in the organs, especially the eyes, the kidneys. And what happens is, because the turnover is very slow, you'll expect that the complications will continue over a period of time. The other explanation is epigenetic changes, meaning that on top of the DNA, you will have a number of changes that will occur because of the poor metabolic control in the body. And this informed the theory of metabolic memory. And this study showed that metabolic memory lasts for at least 10 years. But then what happens after 10 years? We shall see. This slide basically just summarizes what we have said, that patients who are put on intensive therapy and they continue with intensive therapy have almost 50% reduction in eye surgery, CKD, major cardiovascular events are reduced by over 50%. The mortality rate is reduced, especially for those ones who already had advanced complications of microvascular complications. Now, when a number of our colleagues saw that we have this phenomenon called metabolic memory, they did another study, similar study, but in type 2 diabetes, and they found similar findings, that actually patients who are started on intensive therapy early, they can actually continue with the protective effects of that therapy years later. And for type 2 diabetes, they called it legacy effect. So metabolic memory in type 1, legacy effect in type 2, but basically similar process. So we said the metabolic memory lasts approximately 10 years, but then what happens after 10 years? The body forgets of the beneficial effects of the intensive therapy. So for instance, if you had given a patient intensive therapy a while back, and then you come stop it, 10 years later, the body will forget that this patient was on intensive therapy, and the microvascular complications will continue becoming worse and worse. And this phenomenon is now called metabolic amnesia, where the body forgets that the patient ever had benefits of intensive therapy. So after looking at this study, so what? It's important because these studies tell us that the long-term influence of metabolic memory on the risk of micro and macrovascular complications can now fully support implementation of intensive therapy. And intensive therapy aims at maintaining near normal levels of glycemia as early as possible and as long as safely possible in order to limit the risk of complications. So there's scientific proof that we need to implement intensive therapy. And having said that, if you have a patient, a child or adolescent, who can access intensive therapy and you're not transitioning that child on it or starting that child on it, then you're doing a disservice to the child. So the next section is, how do we initiate or switch to basal bolus, having been convinced that these patients need to be on intensive therapy? Initiation of insulin on any child or adolescent is dictated by various factors. And some of these factors include age, in that patients who are younger will need, most likely require lesser doses of insulin. In terms of weight, we actually calculate per kg per day. And then stage of puberty, where prepubertal children will require less insulin, pubertal more insulin, post-pubertal may require less insulin. Duration and phase of diabetes, children who are in honeymoon period, for instance, will require less insulin. Then state of injection sites, if you have swelling or lipohypertrophy, you'll find that there's erratic absorption of insulin, so the patient may require more. Then insulin, nutritional intake and distribution. There has to be a balance between carbohydrates and insulin. In our setup, there are some children who come from food insecure places. So they may just have 1 or 2 meals a day. Again, they will require basal insulin, but for the bolus or pre-meal insulin, you have to tailor make, let it actually be given before the meal that the child will take on that day. Then exercise patterns, you may need to reduce insulin depending on when you are going to exercise. And then results of blood glucose monitoring and glycated hemoglobin will dictate adjustments of the insulin, and intercurrent illness, as we saw, will require adjustments. So what is the correct dose of insulin defined as? The correct dose of insulin is that which achieves the best attainable glycemic control without causing obvious hypoglycemic problems and harmonious growth according to weight and height of children's chart. So we need to have good glycemia. We need to avoid hypoglycemia, and the child should be able to grow and develop. Any requirements of up to 2 units per kg per day, remember you have to consider insulin resistance, re-evaluate diagnosis, and non-compliance. And actually, we do not advise that the patient should be on insulin that is more than 1.2 units per kg. By the time you are reaching there, you need to actually be looking at non-compliance and re-evaluation of the diagnosis. So a basic guide on dosing is this one, where in children who are prepubertal, you want to start them on a dose of 0.5 to 0.7 units per kg per day. And the ones who are pubertal, largely 0.8 to 1 unit per kg per day, but you can go to 1.2 units per kg per day. And adjustments of the dosage is usually 10 to 20% at any given visit, depending on the level of control or lack of the glycemic control. So again, we are going to relook at this. We have actually gone through this. I'm just putting this slide here to remind us that we have 3 arms. We've got the arm of intermediate and short-acting or rapid-acting insulin. And then 40 to 50% of the total daily dose constitutes the NPH. And then 2/3 in the morning, 1/3 in the evening. And then long-acting, it's the same, but you give once a day as opposed to twice a day. Then you have an option of the insulin pump. I'm putting this one here because now we are moving to the case scenarios. Now, first scenario, and I would request that we get very fast at commenting in the chats so that we learn quickly as fast as possible. So the first scenario, we are looking at initiation of insulin. So this is the case. An 11-year-old girl, newly diagnosed type 1 diabetes, presented in diabetic ketoacidosis in a county hospital. The DKA has resolved and transition to subcutaneous insulin is required. The girl is at Turner stage 2 of puberty, meaning that she has started her puberty and her weight is 30 kilos. So the question here is, how much total daily dose of insulin would you give? 11 years, pubertal girl, weighing 30 kilos. How much would be the total daily dose of insulin? So half a minute for that. Get if there's any comment.
Apparently the chat is disabled. There's somebody commented the chat is disabled.
Oh, you can check on the question and answer. I can see some responses coming.
Yeah, now they're on the question and answer.
Mm-hmm. So you can pick some responses there.
So Joanne says 24 units. Dennis Diego, 24 units. Rosemary Mumbi, 21 units. She's going at 0.7. 24 units. Yes, anonymous attendee. Please, we like to hear who we are talking to. Betty Orkere says 0.5 units per kilo for the weight. Deborah Omedo, 30 units at 1 unit per kilo.
Okay, thank you. I think we can stop there. So remember, we are going back to the guide on dosing. For pubertal, we are using a range of 0.8 to 1 unit per kg per day. So anyone who said 24 units or 30 units is right. But usually in a patient who has just come out of DKA, you would want to initiate on a lower dose. So it will be 0.8 times 30, so you get 24 units per day. Okay, then the next question is, you have gotten the total daily dose, which is 24 units. And you inquire with the pharmacy, and the pharmacy has insulin NPH and regular insulin. how much of each would you prescribe? So quickly again, they have insulin, NPH, and regular insulin. Your total daily dose is 24. So how much NPH would you prescribe? How much in the morning, how much in the evening, and how much regular insulin? On our right is just the same case, a pubertal girl, 30 kilos, 11 years. And so we can continue putting in the chat our responses.
So put your answers again on the Q&A.
So if you remember very well, we said NPH should be 40 to 50% of the total daily dose of insulin. So that's where you start from. So I can see responses coming in. So Dr. Linda, you can read some responses.
Sorry, I was muted. So we're starting off with, well, yeah, it's an overlap from the previous question.
I think start from number.
I think I'll start from Naftali. Yeah, sorry?
Yeah, just pick from anywhere, even the latest that are coming in.
Yeah. Okay, NPH 6 units twice a day, regular 3 units 3 times a day. That's Felicity. Consolata Gitonga, 8 units in the morning, 4 units in the evening of NPH. Naftari 1 day, 16 units in the morning, 8 units in the evening. It's giving the whole 24 hours NPH. Then we're moving on to, I talked about Felicity, NPH 6 units twice daily, regular 3 units TDS.
Okay, thank you. We appreciate your many comments. I think we shall stop at that. So remember, the guide is basal, needs to be 40 to 50% of total daily dose. So assuming we are using 50%, we come up with 24 units. 50% of total daily dose, which was 24 units, then that means NPH total dose will be 12 units per day. So 2/3 will be given in the morning. So that means it will be 8 units in the morning and 1/3 in the evening, that is 4 units. And I think one of us got that, or several of us have actually gotten that. So your prescription will read NPH 8 units in the morning and 4 units in the evening. And then the rest is now distributed as pre-meal doses, which will be 4 units pre-meal bolus insulin, but corrected appropriately with the measured glucose levels and the carbohydrate intake. Now, the next question is, in the course of follow-up, the family reports they can access insulin glargine or Lantus. How would your prescription look like? So again, quickly, so how much of Lantus will you prescribe and how much of rapid acting insulin or regular insulin will you prescribe? So quickly in the chat, I think we shall start from number 58. And I really appreciate our fast responses. It's good for learning. So remember we said insulin glargine is a long-acting insulin, so it's given once a day. And it will be 40 to 50% of the total daily dose. And our total daily dose is 24 units, okay?
Brian, 12 units of Lantus. Deborah Meadow, 12 units of Lantus at night. Marianne Wachu, 12 units once daily. Pre-meals rapid 4 units. Maureen Kigara, 12 units of Lantus in the evening. Regular 4 units pre-meals.
Okay, great. Thank you. We stop at that. So yeah, I think we are on the right track. We have actually gotten it. So Lantus is given once a day, preferably in the evening. So 40 to 50% of total daily dose, assuming you're using 50% of the 24 units for our patient, then 12 units will be given in the evening as Lantus. Then the balance of 12 units will be divided in 3 doses as 4 units pre-meal bolus insulin. With follow-up, you correct this pre-meal insulin boluses appropriately. So bravo, congratulations, guys, you're getting it. Now, this is scenario 2, transition. We have now talked about initiation. What about transition? You are convinced that this child cannot be on premix insulin. So how are you going to move from mixed to basal bolus? So let's look at this case. A 7-year-old boy weighing 20 kilos has been on mixed insulin at 8 units AM and 4 units PM with poorly controlled sugars. You want to transition to basal bolus regimen. How would you go about this? Okay. Type in the chat. 7 years, this is prepubertal, weighs 20 kilos, has been on mixed insulin, 8 units AM, 4 units PM. The sugars are poorly controlled. So how would you proceed? It looks like guys are thinking because I'm not seeing any further response in the chat. So let me just take us through a guided approach. So the first thing you want to do is start by getting the recommended total daily dose of insulin for this boy. This boy is 7 years old. He's prepubertal. The recommended dose for prepubertal children is 0.5 to 0.7 units per kg per day. That is the first thing. The second thing, ask yourself, how much total daily dose of insulin has this child been getting, has been on? So for our child, the child was on mixed 8 units in the morning and 4 units. So that means the total daily dose is 12 units. So 12 units divided by 20, what do you get? 12 units divided by 20 kilos, you get 0.6 units per kg per day. And you find that this one is actually within the recommended total daily dose for the age. So the next step you're asking, are the sugars controlled or not? Our patient did not have well-controlled sugars. So if the sugars are not well controlled, you would want to raise the dose slightly, but to fall within the recommended range. If they are controlled, then use the same as the total daily dose and divide the basal and get the bolus doses. So therefore, for our case, we can raise to 0.7 units per kg per day as follows. So 0.7 multiplied by 20, you get 14 units per day as total daily dose. And then remember our basal is either 40% or 50%. So assuming you're using 40%, then it means this child will get 6 units as the basal insulin. That is Lantus if you're using it. If you're using NPH, then you'll have to divide these 6 units into 4 units in the morning and 2 units in the evening. And then the balance, which is 8.4 units, roughly 9 units, should be given in 3 pre-meal boluses. So that translates to 3 units TDS as pre-meal bolus. And I hope we have followed up. We have actually tracked this. So we started by looking at the recommended total daily dose, looked at what the child has been on, asking ourselves, are the sugars controlled? And then slightly adjusting the amount per day, and then going back to what we have been doing, getting the basal and getting the bolus doses. I hope that is clear. A slightly different scenario, and you'll actually get a lot of these scenarios in the field because you have experienced this. Now, this one here is 7-year-old boy weighing 20 kilos, has been on mixed insulin at 14 units in the morning and 8 units in the evening. You want to transition to basal bolus. How do you go about this? I'm not sure whether we should get any responses in the chat. If we can do that, I can give us half a minute to quickly type. It will be interesting to get to know what we are getting. So please go ahead and type. It's similar to the previous case, but with a slight twist. So prepubertal, weighing 20 kilos, is on mixed 14 and 8. So how do you move to basal bolus? Any responses?
None so far in the chat.
Okay, fine. So I will take us through it. But I'm seeing some are coming up now. I'm not sure that they are reducing or increasing. So again, so again, start by getting the recommended total daily dose per age and puberty status. So our child is pre-pubertal. So the recommended is 0.5 to 0.7 units per kg per day. Ask yourself, what has this child been on? You have been on 14 in the morning, 8 in the evening. That's a total of 22 units. So 22 units divided by the weight, which is 20 kilos, it gives us 1.1 units per kg per day. What are you noticing here? 1.1 units per kg per day is very high, much higher than the normal recommended dose for the age. And so it's likely that this child was non-compliant and had been having several hypos. So your next step will be stick to your recommended total daily dose of insulin as follows. 0.5 to 0.7 units per kg per dose. Once you get that, again, get 40 to 50% as your basal, which translates to 6 units in the evening if you're using Lantus, 4 units in the morning, and 2 units in the evening if you're using NPH. Then your regular insulin will be given as 3 units, female bolus. So the catch here is to look at what the child has been on and has been on such a very high dose. And you realize most of our patients on mixed are on very high doses and they keep on getting hypoglycemias. And as a result of that, they will say, I do not inject myself because whenever I inject myself, I feel very bad. So they are non-compliant. There's something we call correction factor, and it's also called insulin sensitivity factor. So if you're using rapid acting insulin, you basically use 100 rule, where you get 100 divided by the total daily dose of insulin. If you're using regular insulin or Actrapid, you'll use 83 rule. You take a constant of 83 divided by the total daily dose of insulin, and it will give you the correction factor. It means that whatever you get, that means that that is the amount of glucose that 1 unit of either rapid acting or short acting insulin will lower the blood glucose by. So the question here is, going back to our patient, our initial patient, 11-year-old girl, newly diagnosed type 1 diabetes, presents in DKA in a county hospital. DKA resolves and transition to subcutaneous insulin is required. The girl is at Turner stage 2 of puberty. Her weight is 30. What is the correction factor? This one you can easily quickly calculate and get. Remember, we did the calculation and we got the total daily dose of insulin to be 24 units. So what will be the correction factor? And a hint, the child has been put on Lantus and Actrapid or regular insulin. So what will be the correction factor? I can see responses coming in.
Okay, 1.3, 1.4, 0.9.
Okay, so remember we go back to this slide. If you're using regular insulin, and remember Actrapid or Humulin R are regular insulin, then you use 83 rule, meaning that you will take a constant of 83 divided by the total daily dose of insulin. So what will our patient's correction factor be? It will be 83 divided by 24. Okay. So that gives us around 3.4. So basically rounding it off to 3. So that means 1 unit of insulin lowers the blood sugar by 3 millimoles, meaning that for every 3 millimoles of sugar above the upper range that you have decided, then you have to add 1 unit of insulin. And this is how you now keep on adjusting the pre-meal bolus insulin. In case the child is on rapid-acting insulin, like Novorapid or Humalog, then you will use a constant of 100 divided by 24. So you get a constant of 4. So that means that 1 unit of insulin will lower the blood glucose by 4 millimoles, sorry, not 3, by 4 millimoles. So for every 4 millimoles of sugar above the upper range, add 1 unit of insulin. So having talked about how to initiate and transition, then it's good to also look at the structured blood glucose monitoring. It's important. You can use a 7-point testing where blood sugar is tested pre-meal and 2 hours post-meal at bedtime and at 3 a.m. or 5 tests a day where the blood glucose is tested before meals at bedtime and 3 a.m. or 3 tests a day, usually done pre-meal to allow for correction of pre-meal hyperglycemia. And we have enough strips nowadays that are being provided by various programs that we are in. So we should be giving enough glucose strips for our patients and teaching them how to monitor the sugar. Finally, how do we adjust insulin doses? You'd expect that by the time the patient is being discharged from the ward, they have known how to monitor their glucose and write down their glucose levels and the amount of insulin that they are giving, plus the correction factor in the diary. And so they'll come with that diary in your clinic. You will review the diary and you will advise on adjustment of insulin doses. So this is basically how you assess high or low blood glucose patterns. If you find that at some intervals we have hypoglycemia, you don't want to just rush to reduce insulin, but you ask yourself, has there been an exercise activity that has perhaps caused hypoglycemia? Is the carbohydrate intake balancing with the insulin regimen that you're giving? Could this patient be having other comorbidities like hypothyroidism or Addison's disease or celiac disease perhaps? Okay, then after you have ruled that out, then you may need to review the insulin doses. In case they have hyperglycemia, it's good to look at the injection sites for lipohypertrophy, because remember there's erratic absorption of insulin if there's lipohypertrophy. And then needs to review the insulin doses. Also ask yourself, is there a balance between the food and the insulin that is being given? So this is basically a chart that talks about the same. For instance, I'm not going to go through the whole of it, it will be in our guidelines. But in case you find that in the morning the patient is waking up with high sugars, then what you may need to do is either increase the dose of evening, intermediate, or long-acting insulin. The other intervention here is you may ask the patient to check the 3 a.m. sugars to rule out what we call Somogy effect. If the patient is coming with hypoglycemia in the morning, several episodes of that, then you may decrease evening, intermediate, or long-acting insulin. And then also check the 3 a.m. To look for either Somogy or Dawn effect. Then, of course, after breakfast, again, you have to look at whatever the breakfast, rapid or short-acting insulin, you may need to decrease or increase accordingly, depending on how the sugars are. So we are going to look at this as an example. So this is a patient that we have been following up. The patient is on Lantus 9 units and Actrapid 3 units TDS. And this is the chart. I actually just copied what the diary has been showing. So this boy came with this kind of chart. And what you can see here is breakfast readings are largely low. Almost all of them are hypoglycemia. They're below 4, except one reading that was 5.1. And then you look at the lunch readings, and most of them are high, except one reading here that was 4.1. The dinner readings are also high, 90%, except one reading. Then you look at this kind of snack that this boy has been getting, either uji, anjera, they're not even indicating how much of anjera, that the boy is getting. Again, the 4 p.m. snack is injera tea bread uji, injera uji. So the question here is, what would you want to adjust? Let's get responses from the chat, please. Okay, responses coming.
It's basically diet. Those are the responses.
Yeah. But then what's happening in the morning? We have low sugars.
Yeah,
what would you want to look at?
Everybody seems to be saying that reduce lantus, that's Winfred Chalo. Increase rapid dose. I don't know which rapid she wants to increase. Evening insulin and evening insulin, this stuff. It seems to be a continuation of something else you said. Joan, diet, snacks, yeah.
Yeah, and all of us are right, actually. So the intervention here will be to reduce the basal insulin, and we need to guide on the type and amount of snacks on this patient. And that's what we actually did with our team. But then the same boy comes later. He brings the HbA1c, 7.3%. Fairly good, we are happy. But then we look at the dairy. The sugars in the morning have kind of normalized. The mom is very keen on giving a healthy snack. And then so you find the lunchtime sugars are behaving. But then the dinner, she tells you, my child has been having a lot of hypoglycemia. And by the way, we saw this patient like it was last week. My child has been having a lot of hypos in the evening. And so when we looked at the diary, we found that the child was not indicating the evening snack. And when we did ask the mother what's happening, and she quickly said, huyu mtoto anacheza sana tangu afunge shule, anatoka after lunch anacheza, hataki kuja kula snack mpaka evening. And so this basically answered our concern. Too much play in the afternoon and forgets to take the afternoon snack. And this is actually contributing to the low sugars in the evening. So having said that, as we come to an end, record keeping is very important. A monitoring diary is needed to record patterns of glycemic control, insulin doses, and amounts of carbohydrates consumed, and adjustments to treatment. And the record book is required every time the child comes for consultation, and it should contain the time and date of the glucose levels, the carbohydrate intake, and the insulin dosage. And remember, when you're dealing with adolescents, again, let them come with the glucometer so that you compare whatever is in the diary and the readings in the glucometer, so that an adolescent doesn't play with your mind. I just put this one, it may not be clear. It's one of the patients we are managing, and this is her diary. So you find that this child is actually indicating the morning sugars, and also indicating how much Actrapid that she's giving herself with corrections. For instance, 13.9, she gave 12 units. When it was 9.3, she gave 10. 11.4, she gave 11. So there's good correction here. She's indicating the meal that she took in the morning. And then at lunchtime, it's still the same with various corrected Actrapid and with the lunch that has been taken. So it's a fairly good diary, except we don't have the pre-bed readings. It's also important to note special events affecting glycemic control, like illness, exercise, or menses, alcohol intake. And hypoglycemic episodes also need to be indicated there, description of the severity and potential alterations in the usual routine to help explain the cause of the event. It's important to note that glucose monitoring records should not be used judgmentally, but as a vehicle for discussing the causes of variability and strategies for improving glycemic control. If a patient comes and the first thing you want to see, we want to ask the patient is, Ebony, patia your diary. What will be happening here is this child will feel that I'm actually being judged. So start by interacting with the child, asking how they are doing at school, how they are doing at exercises, social life, and then discuss whatever is in the diary to see how you can adjust the the glycemic control. So in summary, what we are saying from this discussion is it's important that we transition from fixed ratio combination insulin regimen to intensive regimen. Let's embrace basal bolus. If you have insulin glargine and short-acting or rapid acting insulin, then you give 4 injections per day. If you have NPH and short-acting or rapid-acting, you give 5 injections a day. Monitor sugars at least 4 to 5 times a day. Regular review with the therapeutic team at least monthly is required. Aim at a HbA1c of 7%, and record keeping should not be judgmental. Let's embrace teamwork. We cannot manage these children alone as doctors or clinicians. Let's ensure that we have a dietitian on board, a nurse, clinician, ophthalmologist, psychologist, social worker. Even our colleagues in the pharmacy and the lab are very important. Thank you very much. Over to you, Dr. Linde.
Thank you very much, Phoebe, for an awesome presentation and very insightful. So there are lots of questions on the Q&A, but before we go there, I think the burning question in a number of people's minds is about CPD points. So I think a number of people say they've been attending the talks but have not received their CPDs. So what on earth is going on, and how can they get them? So I don't know, Phoebe, if you're in a position to advise on that, or who is in charge of that?
Yeah, I think Nelson will address that at the end.
Yeah, so Nelson, please address that at the end, because it's actually a recurring question on the comment sections. So if we go, I don't know, Phoebe, are you able to see the questions, or I read them out for you?
You can read.
Yeah,
and
so
I think a number of our colleagues are also in the in the audience. So let's feel free to respond. This being our last webinar.
I responded to 1 or 2 that you'd already covered. So those ones, I think the owners had been maybe logged in late. So Betty Okere starts the question with, it's actually last 24 hours. I think she's talking about Levemir insulin. I think that came into she was putting in a comment. It's actually 24 hours, not 18. That it's head-to-head studies have shown that it's not 14 to 8 hours, but 24 hours. So it was just a comment on her side, Betty Okere. Anonymous attendee, in low resource setup with no NPH and rapid acting, are you then justified to use Mixtard?
Thank you so much, anonymous attendee. Yeah, we need to define what this low resource setup is. We are talking in our context. We have availability of intermediate acting insulin and short acting insulin. We also have availability of long acting insulin. So we have NPH that is available. In CDIC centers, we have Insulatard that is being provided for free for these patients. At the same time, we also have insulin glargine that is being provided for through KEMSA. So yes, we have these options available with us. We have short-acting insulin in form of the regular insulin or the Actrapid. So let's use them. We are not justified to use Mixtard at all. Thank you.
So I think just to add to that, Mixtard, you see, is a pre-mixed insulin. So you'd rather go with what Phoebe is saying, you free mix them. So you do the NPH by itself and the regular insulin by itself, then you can adjust the doses accordingly. Thanks, Phoebe. Now, which insulin? This is from Kishore Kumar Devlok. Which insulin is given in case of emergency, like a patient has myocardial infarction and with rapid increase of blood sugar? Patient was on oral medication. I think maybe meant oral hypoglycemics.
Yeah, thank you so much, Dr. But I'm presuming this is a patient who has type 2 diabetes and has a life-threatening emergency. So this is an acute illness. So any patient, whether it's type 1 or type 2 who has an acute illness, they need to be on insulin. Usually insulin, infusion soluble insulin. Before the patient stabilizes, then they can be transitioned slowly back to oral hypoglycemic medication. with or without basal insulin as recommended by your doctor. So soluble in, insulin as an infusion is good in this case. Thank you.
Thank you. Then Ivan Sundiek is asking, CSII has 2 separate insulin types in the device?
For the insulin pumps, basically use the rapid-acting insulin. So the pump is set to provide the basal insulin and the bolus insulin, but of the same kind of insulin. It's just the response to the glucose excursions as per the settings. Dr. Linda, you can add.
Yeah, so basically the basal is a continuous insulin infusion of the rapid acting. And then depending on the meal ratios, a bolus will be given for the meals or to correct hyperglycemia. So it's just as Dr. Phoebe has said. It's the same insulin, but it can either be timed to give automatic boluses, depending on the kind of setup the machine has, or you physically bolus them, but using the same machine, the same infusion. I hope that is clear. Kuto Mwamkondo wants to know, what's the molecular difference between the rapid-acting and the long-acting insulins?
Molecular difference between the rapid and the long-acting.
And the long-acting, yes.
Yes, so how these insulins have been formulated is the main molecule was the regular insulin. But how they came up with the insulin analogs, that is the rapid-acting and the long-acting, is basically by removal of some molecules and insertion of others that will prolong the duration of action of this insulin in the body. So I think in insulin glargine, we have the myristic kind of addition that was put to prolong the duration of action. And that's basically how the insulin analogs have been formulated, either to stay in the body for a short while, to start acting very fast, or to have a prolonged stay in the body. So basically just an interplay with amino acids, either leucine, isoleucine, and so yeah, I really wouldn't want to go into the details, but basically that's how analog insulins are manufactured.
So the same Kuto is asking, from the chart you presented that represents insulin production in relation to food ingestion, I think rapid-acting insulin is much convenient to the body. I think it means more convenient to the body than long-acting. My question is, are there noted disadvantages or rather complications that are associated with long-term use of long-acting insulin?
Okay, thank you, Kuto. It's I don't know if this question is, I'm not sure whether I've gotten you, but long-term disadvantages or complications of insulin. You know, we are giving insulin because this child does not have insulin. So the child has to receive exogenous insulin. So we are replacing what is not there. The only problem comes in when you give more than the child requires, then you will have hypoglycemia, and prolonged hypoglycemia or repeated hypoglycemia will give you cognitive dysfunction in the long term. Otherwise, we do not have complications of insulin as long as it's getting balanced with the carbohydrates that the child is getting.
And just to add to that, I think your question there, you seem to be more concerned about the fact that the short-acting insulin, rapid-acting insulin, is more convenient to the body than the long-acting. So it seems like he's arguing more for using the long-acting, short-acting in lieu of long-acting insulin. Yeah.
Do you want to respond to that?
I don't think we really have that choice, yeah? Because the long-acting gives you a basal, so it's not a question of one being more convenient than the other. Because now even with the non-diabetic status, you always have insulin, basal insulin secreted by the body and by the pancreas. And then now when there are meals, then their bolus is secreted. So what this kind of basal bolus is basically trying to mimic what the body is doing naturally.
Yeah.
So the bolus, the rapid-acting insulin can't go it alone, and the long-acting can't go it alone either, because it will not go up for the meal for the meal spikes of glucose.
Yeah, thank you, Doc.
Evelyn Jerop, kindly, okay, these are a bit about CPD. CPD issues will be addressed, guys. Sorry, just bear with us. Anonymous attendee, also CPD. Okay, then we had answers. Let me go to yet. I have a child in DKA once, and okay, this is a question from anonymous attendee again. I had a child in DKA once, and the random blood glucose was above 35, really high. My question is, according to the PEDS protocol, they say we give insulin. I wanted clarification on how much and how often, kindly. It would be good to know at what level the anonymous attendee is operating management-wise, because some of these questions are a little bit, they need one-on-one discussion, kind of.
It's true, yeah. Because this patient is actually presented in DKA. I'm not sure whether it was confirmed whether we had ketones done. So if it's DKA, then use the DKA protocol, where you'll give your fluid infusion, insulin infusion monitor till the child comes out of DKA. Then you ask yourself, then how old is this child? If we have come out of DKA, are we pre-pubertal? Then you will use the guide on the dosing that we have discussed today. If it's pre-pubertal, you want to use 0.5 to 0.7 units per kg per day. And out of that, 40 to 50% is basal, and the rest is premier bolus. If it's pubertal, then you want to use 0.8 to 1 unit per kg per day. So so I think that's what I can say, but I think it would be good to, as you said, to discuss one-on-one.
Yeah, discuss one-on-one if you can, anonymous attendee, because he's also kindly asking you to kindly share the slides. They are very insightful. It would be good to touch base with the presenter, anonymous attendee. I think maybe you have more issues that need to be addressed as well. Thank you. We're going on to Betty Okere. Always take the lower number. Okay, she was responding to a question there. Moving on. Kiome Silas says type 2 that has caused marked weight loss. As you control it and maintain. The patient asks on how to regain some weight. Note the patient was not overweight before the onset, which was, this is not very clear what is happening here. Let me read it again. Type 2 that has caused marked weight loss. As you control it and maintain, the patient asks on how to regain some weight. Note that the patient was not overweight before the onset, which was attributed to family planning methods. That's a hanging question. I don't know if you handle it. I'm a bit confused.
It's a bit confusing, but remember, any patient with weight loss and has diabetes, it may be because they are lacking insulin. Even type 2 patients require insulin at some level because it causes pancreatic destruction. So you may need to consider some basal insulin for this patient, even as you give the oral hypoglycemics, but always explore other causes of weight loss, like other autoimmune conditions. Thank you.
So Nancy Mora wants to know, how do you handle children in boarding schools?
Thank you, Dr. Nancy, for that question. Recently, we had a talk on diabetes in school. And the first thing we need to know is any child with a chronic ailment has a right to school to get education. And so we have to educate, first of all, the patient himself or herself, the caregiver, and also the teachers at school need to be educated on how to handle emergencies in diabetes. For insulin, we expect that every school should have a place like a fridge where the insulin needs to be kept. And then they need to be allowed time to inject their insulin. If it's pre-meal, they need to be given time to inject. It should not be able to queue, allowed to be given food that should balance with the insulin requirements of the child. Same to basal requirements. If the child is injecting in the evening or in the morning, they should be facilitated to do the same. So the teaching and non-teaching staff, including the driver and the chefs, need to know how to handle a child with type 1 diabetes. A lot of education goes into that. But I would refer you to the previous presentation by Monica Saulo. When you go to the platform for the KNH research, you'll get that presentation and kindly go through. Thank you.
Good, thanks. Anonymous attendee again wants you to kindly expound on what is basal bolus insulin. I think really you need a one-on-one with the presenter. Yeah. Please, can we know the way? Okay. Thank you for fantastic presentation. That's Joanne Kwamboke. In DKA, this is Thomas asking. In DKA and if in hypokalemia, do you sort out the hypoglycemia or the hypokalemia first?
Okay. Thank you, Thomas, for that. In DKA, if the patient has hypokalemia, you'd want to sort it out first before you start insulin. So when you are giving your first replacement fluids, that 1 hour's hydration fluids, you'd want to start with the replacement with the potassium in it, so that at least the potassium comes up. Then you can start your insulin administration. Remember, as you're giving your insulin, the child should also be on fluids containing KCl. So depending on the level of potassium, ensure that you prioritize the hypokalemia before you go to hyperglycemia. And I will still refer you to the DKA presentation that was done by Dr. Saulo. Thank you.
Okay, so a few comments here on compliments, and thank you for good presentation. Just as says, very well presented and timely. Thank you. When are the guidelines coming out?
Yeah, we had wished that we would have one of our colleagues from the Ministry of Health, but they have been busy celebrating the World Diabetes Day. They will inform us, and in due course, we shall get information on this one.
Ivan Sundieki wants to know, can the organization organize the same for adults and type 2 diabetes?
Thank you, Evans, for that. We appreciate. However, we are not in the position, because this is an initiative by the Paediatric Endocrine Society of Kenya, together with KNH and UON, mainly dealing with type 1 diabetes in children and adolescents. However, your comment is noted, and I believe we have our colleagues here on the forum from the take it up.
Anonymous attendee, sorry, I got confused about calculating the correction factor. You calculate separately, yet the patient is on both NPH and rapid.
Okay. Dr. Limbe, would you want to take us through that? Perhaps you may simplify it.
And then the same anonymous says, thank you for the insightful talks during the pediatric diabetes series. How can the talks be availed? He's asking for it again. KNH Research YouTube page have not updated their recent talks. Okay, so you got confused about calculating the correction factor, and then you calculated separately, and yet the patient is on both NPH and rapid. So correction factor, you take the total dose, yeah? You take the total dose of the insulin used. If they are on rapid insulin, if they're on rapid acting, then you use 100. You divide by the total dose of insulin, and if they're on regular, you use 83. But it's the total amount of insulin injected per day, both the long acting and the short acting, or rapid acting.
Thank you.
Okay. Then we go on to Gideon Nganga. Hey everyone. Okay, CPD points again. Roger's very, very insightful conversation of a patient who has been losing weight and now SAM who has been on mixed insulin. His sugars have been uncontrolled and the dosage has been elevated to the maximum. How can we manage his sugars?
Okay, thank you so much, Rogers, for this question. And it's good you've brought it out. So when you see a patient who has type 1 diabetes is on management with insulin, and the patient is losing weight, the number one, ask yourself, is it the right regimen? Is the patient compliant? Is the patient getting the right dose of insulin? Now, for your case, the patient has been on Mixtard, and you have elevated the dose to the maximum. So if the patient is on maximum and is still losing weight, then there are compliance issues there. And then number two, Mixtard, as we have actually seen, in this presentation is it gives you erratic control of sugar. So the patient will have hyperglycemia with continued weight loss as a result of under-insulinization. And I have seen it in practical practice where you receive patients who initially have been on Mixtard and you put their weights on the growth chart and you find they are way below the 5th centile. When you put them on basal bolus and you talk about compliance issues, the weight starts now going up, increasing up. And that is the presentation we had last week on growth and monitoring. We demonstrated that when you put the patients on basal bolus, there is demonstrable weight increment as long as there is compliance. So for your patient, number one, after this, kindly let's transition to basal bolus. And number two, teach about compliance and support the patient. If we are doing that and still we are losing weight, then ask yourself if we have other concomitant autoimmune conditions that are contributing to weight loss. And don't limit food. Thank you.
Yeah. Sorry, I think we have overshot. Our time is now 8:32. I don't know if we need, we'll have closing remarks, especially about the CPD, then we will have to end our session. There's still many unanswered questions on the chat box. Sorry if we can't get to all the questions, but time is really not on our side right now.
Okay. Yeah, Nelson, thank you, Dr. Limbe. Nelson, do you have, do you want to respond to the CPD points? Nelson, we are not able to hear you. Okay, perhaps I can ask Dr. Priska Molo to comment on behalf of Nelson. And then, since we are coming to the end of this series, I think Dr. Priska can make her closing remarks.
Okay.
Good evening. Regarding the CPD point, I think that information will be availed on the email, but for the doctors, it's supposed to be automatically updated. With regards to the presentations, some have already been uploaded. The initial ones have been uploaded on the KNH YouTube channel, and I believe the later ones are going to be uploaded soon. And I think just my final comments, I just want to thank everyone who has participated in this pediatric diabetes series webinars that we've been having for the last, I think 2 months now. And I think I believe we have learned a lot and we have covered a lot in diabetes. And I believe the topic we've had today is one of the most important ones for us as an endocrinologist in trying to improve the management of our patients, especially as far as using the correct insulin regimens is concerned. And one of our goals is to transition 100% of our patients from the premix insulin to the ideal insulin regimen, which is basal bolus insulin. And I think with that, I can say that we have had a successful webinar series, and I hope everyone has benefited. And thank you. Over to you, Phoebe and Dr. Limbe.
Yes,
okay, thank you so much. Dr. Limbe, you can go ahead.
Thank you, Priska, for those remarks. And mine is also to say thanks to all the attendees. And I hope it's been a beneficial session and also a beneficial series overall. Thanks so much, everyone, for attending. Yes, Phoebe?
Yeah, thank you again for attending kindly. We have seen the reason as to why we need to transition these children from Mixtard to basal bolus. We have the commodities, we have the insulins in our setup, we have the glucose strips, we have the glucometers. Let's utilize them. We are aiming at 100% transition. So let's do this together. In case you have a challenge, feel free to consult any one of us, and we shall aid you in transitioning this child or adolescent. Otherwise, thank you so much. KNH Research, thank you, Dr. Priska, for this opportunity. Thank you, Dr. Limbe. And yeah, we come to the end of this discussion. Have a pleasant evening ahead.
Bye, everyone. Thank you.
Bye-bye.